Right. Hi Selena.
Hello.
We're going to do a teaching session on stuff that we've already previously discussed. Generally going by your learning need.
Yeah.
We've identified ENT as one particular area.
Yes, definitely.
Would you care to just give us a bit of background and talk me through what led to this learning need without any specifics, patient confidential stuff, and what we've done and what we're going to do today.
Okay. A patient came to see me at consultation and she was complaining of symptoms which sounded very much like sinusitis. And she said that she'd had it a couple of times in the past. She wasn't clear about the timeline, but she said she felt that she'd like to be referred for a specialist opinion because to avoid the recurrences. She didn't have a fever at the time and there weren't any signs or any points in the history that led me to believe she had a bacterial infection. So I recommended that she try some nasal sprays and advised her to come back to me if her symptoms worsened. And I said that we could then think about whether it was suitable or necessary to refer her for an opinion. And I just wanted to, because it's quite a common condition, talk about things like when you first of all, how to differentiate between sort of viral and bacterial. I know it's quite difficult if there's any things that really would point you in one direction or the other.
Yeah. And
criteria whereby you would think about referring somebody. And what we can just do for people here, just in the immediate sense to help them out.
Yeah.
So.
Okay. I mean, a couple more things just I'd like to pick up on. You said nasal sprays. What did you mean by that?
Well,
did you mean over the counter?
Yes, she tried over the counter ones when she first had her initial episode. She said she found helpful, so I advised that she try them again. And I also just advised ibuprofen as a simple analgesia and to see how her symptoms responded to that and then to make another appointment with me. Okay. Because I didn't want to prescribe, I know that steroid sprays have a role, but I didn't want to prescribe one too early in the duration because I wasn't sure if it was the right thing to do. Okay,
so just to recap in terms of your learning need today, the whole topic of sinusitis or rhinosinusitis is to be covered, and specifically how one might go about distinguishing between infective viral, infected bacterial, perhaps distinguishing between altogether infective and non-infective causes, as you've alluded to in the case, the criteria one might use, and the management algorithm one might use, and finally how you might deal with it in primary care rather than refer at the offset.
Exactly, yes.
So what we do is so, you know, this is just a recap of what we've already talked about.
Yes.
What's happened since you identified this learning need?
I've done some reading myself from some books I have, and also read the information that she sent me about some of the latest guidelines. And as I said, one of the term that's, instead of just sinusitis, it's really rhinosinusitis, because you very rarely get one without the other. They rarely happen in isolation. And there was some hints, there was some criteria that you would use to distinguish between the bacterial and viral infections, which I found quite useful. I had an idea about them anyway, just in terms of sort of if there's any discharge, like purulent mucus and things. Fever can be present in viral or bacterial, so that's not a very good way of distinguishing. So that was one thing that I found helpful. And also, in terms of what we do, this is what I wanted to ask you about. In the guidelines that I read, it said that there's an option, if someone does present and you suspect it's bacterial, you can have watchful waiting for 7 days and ask them to come back before you immediately give antibiotics. And I just wanted to talk to you about that, and if that's how you would advise me with patients.
Sure. So again, let's put a note on that in terms of watchful waiting. So you said you mentioned you'd read some literature of your own.
Yes, yeah.
What were you looking at?
I looked in. I started off it's the Oxford, like General Practice Oxford Handbook. I looked at some Up to Date, the website, but I found, it's a similar information which you actually sent me, but I found yours easier to read.
Yeah.
It usually isn't. And I did also read patient.co.uk, just because that's what we give patients. So I kind of wanted to know what the information that they would have perhaps when they walk in to see me, or because we often give patients leaflets.
Yeah. And as you know, I'm a big advocate of doing that, because
so
if you understand what patients are doing, then you can also talk to them in language that they understand and know what you're about to handle in terms of information. So I guess in starting to break this down, the first thing I'd like to draw your attention to is, do you feel you understand clinical criteria from your Oxford reference plus the standard stuff you looked at that I sent you? How you would distinguish someone that comes in with, say, acute sinusitis? How would you define it? How would you look for it, and what would you do?
Okay. Well, acute sinusitis can often follow an upper respiratory tract infection. So they might say, I've had sneezing, what have you, runny nose, and then ask for things that might describe that the nose feels blocked, facial pain. Sometimes it can be quite, from a lot of what I've read, non-specific in the sense people complain of a headache, toothache sometimes, and they would sometimes complain of sort of mucus discharge from the nose, which may or may not be discoloured, like dark yellow or green or something. And also sometimes the pain can get worse when they lean forward, it's worse in the morning, things like that.
And I've seen you ask these questions in consultation, so it's good so that you're distinguishing a headache.
Yeah.
So you've got the headache symptoms, you've got the discharge. Any other signs, symptoms to look for? Losing sense of smell. Yeah. I suppose some patients may describe facial pain, headache, but there's a bit of a blur in between the two, but facial pain specifically. Yes, I look for that too. Yeah. I mean, specifically if people are getting pain over their maxillary sinuses or ethmoid or paranasal. So it's almost like, as part of my exam I almost do palpate over the sinuses, and that's quite helpful. Anything to look for on examination other than sinus tenderness? It would be expected that you examine ears and throat as you would for someone presenting with an upper respiratory tract infection type symptoms. And one of the things I was going to ask you today is, I'm sorry if we might be veering off to a different subject, but there was in the literature, there was the presence of polyps or nasal polyps, and I think I read somewhere that we could possibly see them. It's sometimes possible to see them just with a pen torch, and I wondered if that would be the case, or whether they need to be referred to have to see the end. It's an endoscopic investigation that an ear, nose and throat doctor or surgeon would use. Potentially, yes. But would we be expected to at least say that we've looked for polyps, and would we be able to see them? Right. That's a very clear question. I mean, in terms of the examination, you'd also do things like temperature. Of course, sorry. But in terms of examination of the nose, polyps are very easily identified on examination in some instances. Right. The way one tends to, when one's examining, looking at the nostrils with a otoscope, technically it's a bit tricky to actually look up someone's nostrils whilst not having them sneeze on you or something. My personal technique is to actually get the patient to hold their nostril for me, and then I'll look down each nostril slowly.